My name is Marie Duguet. I teach medical law and bioethics at Toulouse University, and I am involved in an INSERM unit which is the INSERM unit dedicated to public health. And in this unit, we have a research team on elderly and geriatrics. So this is why I have been involved in this research. I would like to thank l'association monégasque pour la recherche sur la maladie Alzheimer, puisque j'ai été gentiment invitée I have been invited to attend this conference. Sorry about the French. And I'm very happy to be here because since many years we cooperate with Tunisia, not with Morocco, but with Tunisia. And our INSERM unit had a research project, a cooperative research project, and we are very aware about this question. And this is very complementary to the presentation you just made. So the presentation I made is about a study, a survey which is sponsored by Fondation Médéric Alzheimer, and in this study we are trying to see what is the situation of the elderly immigrants in France. And my colleague Marie Duguet, which is at the first row, will help me for answering the question, because she is an anthropologist and she performs the interview of in this project. But this project is not only on interview, and we have some research on literature and on law. So this is complementary with this part of the survey, which is anthropological and sociological interview. So this survey, which is called MRTC, founded by Fondation Médéric Alzheimer, it's a qualitative study because it is really difficult when we want to evaluate the situation. It is difficult to have statistics, so we decide to have a qualitative study. And the goal of our study is to see what are the questions, what are the problems. We are not going to see what is the solution, and we are not going to see this is exactly how many people is. We don't want to have statistics. We just want to identify the problem, the situation, the issue, and maybe to suggest, this will be the second part of the project, to make suggestions. So we have first analysis of the literature, of the rights of the patients, migrants, and the situation of elderly migrants. And this is the study is ongoing. And now we will present the relevant elements. So we have interviews, and Marie Duguet made the interviews, and I contribute to the interviews as well, to patient, caregivers, and family, and also health professionals. So this is the result some result about this survey. So what about the literature? So the literature, the question in the literature we were looking at was exactly what is the situation, what is the demography, and all different teams and many demographs, sociology, what did they say about the situation of immigrants? So France is faced with an aging immigrant population. Elderly people from Maghreb represent 10% of the population, but institution hosting 4% of elderly immigrants, but mainly women, and from European countries, but very few from the Maghreb. So this is what you already said, and this is our problem, because we say, where are they? Where are they? Because they have, I will explain, they can go, but they don't. So this is one of our questions. You partially answer to this, but things are changing. So the first thing is, what are the rights of the immigrants? Because this is an ethical point of view. I am specialist in bioethics and ethics, and the Article 7 of the Code of Medical Ethics says that we should take care of this patient without whatever the ethnicity or religion. And we have this law in France, which is the 2002 law about the rights of a patient, and this law is the same for everybody, for every patient. So protection of health has to respect the dignity. And I would like to be very clear with this question of dignity, because when we think that when we think about elderly patients from countries, but whatever the elderly person, we should respect their dignity. And when we speak about the dignity of the old patient, as we are members of the same community, of the same habits, of the same culture, we know what is the dignity, but we don't have any really good idea about what the opinion of the dignity for foreign people. So the right to appropriate care and treatment, and as well, patients should not be discriminated, because I will say things about it later. So in France we have an assistantship, which is very interesting, according to what you said about the resource and the proposal that can be done to this patient. So we have the personal autonomy allowance, and this is there is no discrimination. This is possible for these immigrants. So if they have access to SAL, for example, I will give you some statistics because this is easy to find. Only 139 people from foreign nationality you can see the figure, on more than 15,000 are recipients of this autonomy allowance, only 4%, including, so this is the country outside for Europe, it's only 1.3%, which means from the person from Malta or outside. So this is, they have access, they can have it, but they don't ask for it. So this is a problem. So what are the elements of literature that we have confirmed in the interview? And I thanks again Jenny about that. So managing dependency. You said that the dependency management of elderly migrant remains essentially on the family, and it is more a burden than a choice for the family living in France. The study of Nadej Bartowiak says that the reluctance to enter into institution is maintained by the fear of cultural abuse and of our language barrier, and the difficulties in financial and administrative matters. But the difficulty, Nadej, it's a very interesting study, survey. Nadej said that old elderly people think that there will be financial and administrative difficulties, but it is not true. It is difficult for everybody, but it is not really, there is no barrier. But the question of cultural abuse is something that it's really in the thinking of all these families. The second consequence is what we found in the literature, and which is confirmed by our survey, our interview, is that these old elderly patients, they don't have a diagnosis enough early as the people living in France. So this is the clinical evaluation of dementia requires a good verbal communication. So this is a barrier. And there is a lack of cognitive tests which are adapted to this population. This has raised in several centers. So there is a study conducted in 17 countries in France, and 80% of the center reported that patients from ethnic minorities represent less than 5%. So this is a situation in all the countries in Europe. So this is a reality, and this is a problem because a part of this population living in Europe, is out of all the thing they can have. They can have health, they can have diagnosis, and so this is a quite a big problem. So another question is the representation of aging and dementia. There is a survey for Muqaddam who analyzed the 13 articles published in US and UK, and these are arguments related to ethnicity mentioned to prevent, so that's why they don't have diagnosis. There were dementia, because these people think that in this population they think that dementia is a consequence of aging, but this is not only for these people. No, so many people think that thought before that dementia was a consequence of aging. And to take care of a person with dementia is an obligation whose family is responsible. And some of them, say that they have experience of shame and stigmatization. And I think this is something that when it happens once, people think that it happens always. So this is one of the representation, and as well the belief that nothing can be done, and this is not only a belief for immigrants. So now we are going to the social factors, the difference with status between men and women. So I have just close to me a specialist coming from Morocco. It's difficult to me because I'm a lady, I'm a woman, and you are a man. So, but this is something that we can find, and we can find in the interview. And I think I'm not criticizing, but it's a reality. So, difference in status between men and women. The home is the domain of a woman, while the man is passing more in the public space. So precarity arises especially for women. We are forced to depend on the solidarity of their son. All men who have a pension can help the family and maintain their privilege, and their status is respected. The men mostly attended the Koenig school. I'm saying that some old people, they went to school, men more than old women. It was 40 or 50 years ago in the past, so it's not a criticism. And the education received by the father is sacred, and the principles are really respected. So, secondly, traditionally, the wife takes care of her husband, and especially since she's younger. The age difference at marriage, in French, people say, people from North Africa, they have young ones. But this is not a reality. This marriage between persons, and we have statistics about it, we have good information about it. This occurred the same marriage age, but the man has easily, I work just like this. The man has easily the possibility of divorce, of repudiation, to take a new wife. The widower remarries the man, but not the woman. So this practice is sometimes encouraged by the family. We could have a good discussion. Yes, in the past. Yes. So this is in the past, but this is the situation we have to face now. It's keep in mind, and sometimes it could be a reality, because these people, we are talking about people of 80. It was, 40 years before they can change. So, and consequently, the older men are less likely single than women which are widowed or divorced. This is really a situation we have in France. So, aging of immigrants. So, a study conducted in our region, Mediterranean region, for elderly workers who migrated in France, shown that the major paradox of older immigrants expected to return to their country of origin for their or to end their days. But this is not the reality. They do not do that. Some, but not all. Most of them travel between the two countries. Some of them are forced to return into France alone, several months a year, in order to continue to receive their pension. And most of the elderly of immigrants replicate the models of family support to older and raise a question about the risk of confinement and neglect of older. This is important to be aware about the situation, because we have, and I will explain later, we have some old people coming back to France for 3 or 4 months each year, and they are alone. So I will explain about that. And I think this is one of the big questions we have. So about the intra-family support, you said, and we agree with that, the importance of religion and tradition, not only religion, but tradition, I speak about culture, of filial piety, are very strong, since almost like 80% of Muslims consider it is a duty for the child to host a dependent patient, against 30% for the Catholics. Half of the Maghrebi wish to be hosted by their children. For Tunisian origin, do we have Tunisian here? Yes, Tunisian origin. For example, men from Tunisia often think that children should support their parents. This is the opinion of a man from Tunisia. The image of a patriarch. So this is something that we have found in some of the interview, not in all, but in some of the interview. In family tradition, the old man prefers that his wife or his daughter takes care of him in the daily life and care of the body, because we have this question about the care of the body of a subject. The old woman, alone, widow, divorced, or destitute, wants to the help of the children for the intervention rather than the intervention of a third party. So an excessive respect for the image of a patriarch has led family to refuse the intervention of all outside healthcare providers. We made interviews in SACS. In our survey, we had interviewed interviews in Toulouse and around, in Paris as well. And we had a part of our survey interviews of professionals in the city of Sfax, and they say that the healthcare provider, the professionals said that they refuse the intervention of healthcare outside professionals. And it's the same situation for the institutionalization for men in France. Men, but for women, they are more in elderly home than the men. So these remedies, however, seems more really accepted for women in Sfax and in France, especially for precarious women to be in establishment. The question of illiteracy. So all the time people say, we cannot get information. It is difficult because they are illiterate. But the situation, difficulty in diagnosis of relationship related to illiteracy is found in all elderly immigrants, not only with people coming from north of Africa. It's the same for us with people, immigrants coming from Portugal, so it's exactly the same. But I have to say something, and this is very important. The lack of education, when I say education, I say going to school, even if all of the men went to Quranic school. The lack of education does not imply that old persons are not educated. They transmit strong values and dignity, and this for me, this is very important because they are really respected. The education is not really the basis of communication and everything. So we can have different values without being educated at school. What's the professional representation in France? regarding all migrants, professionals have a representation of family solidarity, which is increasingly more and more contradicted by the fact. The argument of a higher tolerance in immigrant families, the population in the host country with regard to this patient is too often advanced. So some professionals say, oh, but this family, they really like to have an elderly person. Everything is okay, but you said in your presentation that this is a heavy burden because the person in the night goes everywhere. This is a heavy burden. So we cannot say anymore that if a family that it is easy for this family. No, it's not easy for this family, and it's not normal for this family. So the particularity of family management of cognitive disorder, qualified by professional as cultural, may actually be an obstacle to diagnosis, which refers to the lack of access to healthcare for older immigrants. So what we want to say, and this we want to highlight this situation, it is easy for professionals to say, oh, this is, they are much better at home, this is okay to be home, the family take care of everything is okay. No, I don't think that everything is okay. We should have a glance about what is the situation. So there is an evolution when you say this was in the old time, and I think it's the same for the situation in your country. There is a transformation of solidarities. There is really much more solidarity in Maghrebin family than we have in Catholic family, I told you. But I think that there is something different as well. For example, there is the situation is changing. So the intergenerational cohabitation means a transformation of solidarity. Young immigrants arrived in France who have realized their desire to integrate the French approach shows a lower propensity to welcome at home a dependent relative, and they prefer for themselves to remain at home than to be hosted by their children. So this is starting to be a reality. The solidarity remains, but people want to not to be all together, but to be separate, with a very important link between. So less than 1 woman in 4 in the Europe would accept to host an elderly patient, against 3 or 4 in Malta. This is the survey which has conducted by Claudine Atias-Santu. The question of the caregivers. The caregivers are recruited mainly in the close family. 57% are spouses and 34% are children. The daughters are at the center of the family support. You see 25%. And some, it's difficult to say, but some of daughters are quite rather obliged to stop their job, to stay at the family, and to help the old parents. Outside professionals represent only 2% of the caregivers, and 3 or 4 are women. So the daughter shows strong solidarity with their parents, helping them in everyday life and managing administrative issues. And this solidarity is fostered by family as a cultural heritage to promote the respect of the elders. So they really agree to, they say, we want to do, it's a duty, the daughter says that. But it's very hard for them to, it's a very good, it's a very hard burden. So, and I will end with this. Out of the survey we made in the literature, I put so many references about that. Out of the interview we had, we have not finished all it's an ongoing survey. We don't finish our interview. But I think that we should focus about some situations which are very difficult, which is the situation of the isolated migrants, because these migrants are really, really in difficulties. Home for Migrant Workers hosts 84 of elderly immigrants, mostly men from African origin. Some of them living far from their family represent early and heavy dependence. So this is one of our big concerns. We don't have really this situation in Toulouse and in Midi-Pyrénées region, but this is the situation we have to face in Paris and in this part. So because a part of our survey is conducted around Paris and so Caroline Desprez described the self-concern. There is a low value as to this person. There is a low value as seen to its own existence, with restriction of the needs, a kind of self-censorship. So these people, they say, we don't need anything. They go to France and they stay in their room. So in my opinion, this is terrible. The refusal of a denial of care is an act of autonomy with regard to the conventional medicine and to turn to the traditional alternative medicine in some cases. So we have to think about that, because this is sometimes the reality and about the recent presentation of the pathology as well. They need a special attention. They need a special attention for diagnosis, treatment, and assistance. And this should be done with respect to their culture. And this is important. I'm not saying we always need to know everything, but we need to know the people that have very important situation, just like a woman should to take care of a man. Some precaution should be taken. So this is something important, because these elected immigrants, statistically we can know, and this is the survey of Mrs. Bartowiak. And in my conclusion, solidarity, I would say that solidarity in family is decreasing, but remains the basis of the care and the support to the elderly. So they do not want to have them maybe at home, but they really want to do something, and the solidarity exists really. The access to care and protection is possible, but the respect of all persons and the will to keep them in the family may limit the diagnosis and the access to specific care. So we should be aware of that. It's a reality. We should try to suggest solution. So relevant information should be developed in the appropriate means. And I really appreciate what you presented in your presentation, what the means you use for these people. And I think we could think about that. And younger generation in France and in Tunisia agreed to take into consideration the special need, but the representation of the Alzheimer need to change in the public and among the professionals. I think we are too much with ideas that are not the reality, and ideas that cannot help that kind of patient. So thank you for your kind attention, and maybe if you have questions, I will.
Thank you very much to Marie Duguet for this very nice presentation of cultural aspects. Of course, I think maybe we do not agree for some points, but I think what we presented, of course, gives a very clear idea about what was happening. Maybe I can say Morocco. I think so. Maybe in Tunisia, same thing. Maybe 20 years or 15 years ago. But I think also there is a particularity, because the Maghrebian people living in France, they are facing a very big cultural problem, because they are from the old generation, and sometimes they have kids they want to live in the new generation. So it's three very different levels. So I think we have not this kind of people in Morocco or in Tunisia. So they are from old ages, for example, for the grandparents. For the sons, they are in male ages, and the young, they want to live in French ages. So it's really very, very difficult for them. And also I have a question. I think you talked about dignity. I think it's a very important point. I think also we face these things in Morocco. I think Morocco, Tunisia, Algeria, we have maybe 60% of native Moroccans. They're not speaking Arabic. I'm also native Moroccan, I'm not Arabic. So our language is particular, it's Amazigh, it's 3 years old language. Maybe Arabic is 20th century old. So sometimes you have patients come in, they are native Moroccan, so they don't speak Arabic, and the doctor, it does not speak Amazigh, so it's a very, very big miss with the patient, and especially with the family. So I think it's the same problem between Arabic and maybe French in France or in other countries, but also we face these problems in Morocco. I don't know if you have...
This problem is not existing in Tunisia because there is one language, Arabic language. But there is more problem from Tunisia living in Monaco. Nous avions envoyé de Monaco un malade tunisien pour faire le test en Tunisie et on l'a envoyé à Monaco. Maintenant, on reçoit. Je m'excuse. I'm sorry, my English is very, very bad. Then I speak in French and Federico. Nous recevons déjà, on a reçu 2 fois des immigrants donc de Monaco et de France qui sont venus en Tunisie faire les tests avec leurs enfants et on envoie maintenant les dossiers des malades parce qu'il y a une grande difficulté de langue, on est conscient. Et je voulais faire une petite remarque. Ah oui, je suis d'accord.
Tunisien.
She's saying that she's actually received patients who have come from France and Monaco who are Tunisian, but they go to Tunisia on behalf of France and Monaco to be treated, to have tests, and then the tests are sent back to the
to have Tunisian tests because
they don't understand otherwise because of the language barrier.
Je voulais juste faire une remarque. Vous avez parlé du fait que les gens, quand ils sont chez eux, n'ont pas la même prise en charge. C'est-à-dire il y a un mauvais diagnostic et un manque de diagnostic. Et c'est le problème en Tunisie. Je suppose que c'est aussi le problème au Maroc. C'est-à-dire que les gens refusent cette maladie. Vous l'avez bien dit, il faut changer les mentalités. En Tunisie, les gens refusent la maladie et donc ils refusent le diagnostic. Donc c'est ce qui fait la difficulté. Je ne sais pas au Maroc, ça doit être la même chose. Nous, on refuse. Par principe, les Tunisiens refusent cette maladie.
I think it's the same thing also in Morocco.
Sorry, just to translate, because I don't think everyone understands. And she was saying in Tunisia and probably in Morocco as well, the problem is that people are refusing the diagnostic. So they're going to be diagnosed with a doctor, but they refuse the illness. They will not, they just say, okay, well, I've been diagnosed with illness, but they refuse this diagnosis. And that's a problem, and we need to change the mentality and the way things are seen.
That's a common problem in all the Arab regions. Everybody is Alzheimer's. And I think it's not just peculiar to this study or immigration and stuff. It's just our culture. That's the common grounds that we have in the Arab world. I don't know about the others.
maybe it's a second barrier.
Well, this is why it exists. It exists to take away the stigma that is around Alzheimer's disease, and this is our main objective to start with while we're doing awareness. So
I think we have
Yes.
to finish the session.
Thank you very much. If there is no other questions, so I think I